The COVID-19 pandemic has been ravaging mankind for the better part of 1 year. At the moment, more than 1.3 million persons have died from complications traceable to the virus. Every country in the world has had varied unpleasant experiences arising from COVID-19. But initial widespread fears that Africa would likely take a direct hit from the pandemic owing to the deplorable condition of her health infrastructure have proved to be completely off the mark. Rather than that, the major epicenters of the pandemic have been first China, and then Europe and the United States, jurisdictions with far advanced medical infrastructure and know-how. How has Africa been able to dodge the bullet? Well, it's all been captured in a comprehensive report co-authored by a team of top medical doctors from the continent, led by Nigeria's Dr. Ebun Bamgboye, a consultant physician and nephrologist and clinical director at St. Nicholas Hospital here in Lagos. Dr. Bamgboye now joins us to discuss the report he co-authored with a number of doctors on the continent on the reason why Africa has thus far been spared the full wrath of the COVID-19 pandemic. Welcome to the program. Good morning, Doctor.
Good morning, and thanks for having me.
Good morning, and thank you for joining us. The paper that Mundu Abiola referred to is titled COVID-19 Pandemic. Is Africa different? And that's a question that many people have asked. There have been many reports, all kinds of reasons advanced as to why the seroprevalence level, the mortality rate level for COVID-19 appear to be lower in Africa, different from what happens elsewhere in Asia, in Europe, and in the United States. But why is Africa different? What are your findings?
Well, first of all, the report came about because the African Association of Nephrology was of the impression that given the projections and given the fact that kidney failure is one of the more common severe complications of COVID, that it wasn't going to be unlikely that Africa was going to be very badly affected. So an expert committee was set up by the African Association of Nephrology to develop guidelines for the continent to enable us manage the kidney complications and the complications of our patients with kidney failure developing COVID. So the expert committee consisted of several individuals, I from Nigeria, a doctor from Ghana, Senegal, 3 from South Africa, 2 from Kenya, and 3 from Egypt. And we met over several weeks to develop the guidelines which were eventually published. But in the process of developing the guidelines and discussions during the development, we found that evidently things were not quite as had been projected and predicted. And that led to the decision for us to put together the paper, which is the aftermath of which is the paper that was published by the National Journal in America, more or less detailing the differences that we found between Africa and other continents, and even differences within the African continent itself. I think several things were thrown up by that review. I would believe that probably the major reason for the difference that we're seeing is the age demographics that we find in Africa. We find that the median age in Africa is actually 18 years, meaning that 50% of the individuals in Africa, particularly in sub-Saharan Africa, are actually 18 years or younger. And we recognize that the disease has clearly shown that it's a disease worse in the elderly. The elderly are 4 times more likely to get it than younger people, and when they do get it, they're more likely to develop the severe complications of the disease. So given that our age profile in the continent is so young, that probably is one of the more pronounced reasons why we seemingly seemed to be spared compared to what has happened in other continents of the world. It's not that the young people don't get it, but when they do get it, they're less likely to have the more severe complications of the disease. And we're finding that the majority of them tend to be asymptomatic completely, They don't have any symptoms, and those that are symptomatic are very mildly so. And they're so mild that it can very often be mistaken for other illnesses. So I think that is probably the major reason, coupled with the fact that you find that because of the expectancy of what we have here in Africa, you find that in Nigeria, life expectancy is about 50 years, compared with the life expectancy in Europe or America, where you have numbers closer to 70 and 80 years. We know that only about 3% of individuals in Africa are over the age of 65 years, whilst if you compare that with what happens in Europe, close to 20% of individuals are over the age of 65. So that age profile in itself is a significant factor, coupled with the fact that many of the risk factors that have been associated with severity of disease are even more common amongst the elderly people and more common in more affluent societies. So you find, for instance, obesity is less common in sub-Saharan Africa than it is in Europe or America. Diabetes is about 4.4% in sub-Saharan Africa and closer to 10-20% in Europe and America. And we know that these two conditions, these two coexisting comorbidities, generally tend to portend more grave severity when individuals with these conditions contract the COVID-19 disease.
Thank you, Doctor. What I have to say
there are a few other reasons.
Yeah, we'll come to that if I can come in here.
Outlined in the report itself.
Which we will come to. Which we will come to, Doctor. Can I ask a question?
Out of the country, more seeding that there is. We do know that the flights into Africa are a fraction of what happens in other parts of the world. So, for instance, you find that the Hartsfield-Jackson Airport in Atlanta in America has about 105 million passengers every year. That was the count in 2018. The busiest country airline-wise in Africa is South Africa. South Africa has roughly about 35 million passengers in the whole country, and just compare that to what happens at just one airport in the United States of America. The interesting thing that the report also showed is that if you plot a graph of the total number of flights with the total number of cases, there's almost a complete correlation between the two. So you find that the busiest airports are in South Africa, Morocco, Egypt, Ethiopia, and Kenya. And if you look at the numbers now, in terms of the prevalence of the condition in the different countries in Africa, it also seems to mirror. And the importance of that is that the busier your airport, the more likely that individuals will come in from places where the prevalence of the condition is higher, and the more likely that the disease would increase in your individual country.
Indeed, Doctor.
That factor is known as the seeding effect.
Indeed. If I may come in here.
These are two of the more prominent reasons. The third reason, of course, would be the fact that we also believe that to some extent, your exposure to various other infections, and infections that in some way might be similar to COVID, might have helped induce individuals' immunities to an extent that when they come across COVID or the SARS coronavirus 2, the likelihood of their contracting it, and if they do contract it, the likelihood that they will have a severe form of the illness is much less.
Right. Okay, real quickly, if you can hear me, Doctor, a very interesting report and great work you have done, to be able to look at all the varying factors. But I want to talk about the perceived immunity, because we've had other corona, viruses or corona-related viruses and the surge of malaria. You postulated that too in the report. You talked a little bit about that. Could that also be a factor? Because when people looked at the poor health infrastructure we have in Africa, Bill Gates' wife, for instance, Melinda Gates, did say it was going to be body bags everywhere, but that's not the case. Could that also be a factor? Could that have prepared us even better for all of this?
Yes, if I heard your question right, you're wondering whether you're wondering whether our exposure to other infections like malaria, typhoid, and other coronavirus could have primed our immunity. And that is a factor that has also been seen. Because in individuals who have been found not to be positive for the COVID disease, and samples have been taken, they've actually been able to identify cross-reactive neutralizing antibodies. And the suggestion of that is that it's possible that individuals might have come across some other coronavirus, not the SARS-CoV-2 virus, which is responsible for COVID, to which antibody has been mounted. And that antibody, or those antibodies, actually cross-react and actually are partly or partially protective against the COVID disease itself. So that in itself is also a factor that has been projected, but that is yet to be confirmed.
Well, Dr. Bamgboye, I think Tundun has a question for you before I jump in. Tundun, please go ahead.
Well, I was going to ask a question about, well, first of all, I should say, like Rufai did, I found it really refreshing to read a report about Africa beating the odds for a change, rather than how Africa is always at the bottom of every single imaginable index. So that was great to read. But I was going to ask a question about the BCG vaccine. I found that aspect that you raised very interesting. Can you expand on how that could have helped to save our bacon in Africa?
Well, what is known about the BCG vaccine, even though it's predominantly intended to protect you against tuberculosis, what has been found is that it has other effects, essentially, that also seem to protect you against the COVID disease. And it's just odd that it's been found that countries that continue to administer the BCG vaccine, both in Africa and also in Europe, seemingly seem to have better statistics when it comes to exposure to the COVID disease itself. So whether that is an aftermath of the vaccine or is just a coincidental finding, which might relate to another factor, which the report actually also threw up. The fact that when you look at the Human Development Index and the Health Access and Quality Index, which essentially is a measure of the quality of your healthcare and the quality of your level of development as a nation, we found that the better developed the country was, be it in Europe and America, the higher the Human Development Index, the better your Health Access and Quality Index, the more the number of illnesses that the more the number of cases of COVID that you had. That we found quite odd. And what that meant, or what I have inferred, or we as a group have inferred from that, is that it appears that the less exposed you are to common infections, the less your immunity is primed to protect you against other infections that you might not even, in fact, have been exposed to in the past. And that's why you find that individuals that exist in countries where there's no malaria, where there's no diarrhea, vomiting, the incidence of respiratory tract infections are seemingly low, except during flu seasons. You find that all those individuals, their immunity appears not to have been primed. And in our own environment where we have so many such endemic illnesses to contend with, there's malaria, there's typhoid, there's gastroenteritis, there are various forms of respiratory tract infections, you find that our immunity seemingly has been primed. And because of that primed immunity, we have developed some antibodies that seemingly seem to be protecting us from the SARS-CoV-2 virus itself. But like I had mentioned earlier, I mean, these are speculations, and a lot of research still needs to be done to actually confirm whether this is true. And it's really not a reason for us to be complacent, because whether we like it or not, individuals are still contracting the illness, and several individuals, particularly those who have the comorbid issues that we know are associated with severity of illness. If you're over the age of 60, if you're obese, if you're diabetic, if you're hypertensive, if you have respiratory tract chronic illnesses like asthma, if you're being treated with conditions that lower your immunity. So people with post-transplant individuals, people with retroviral disease, people on steroids for whatever reason. All those individuals are more likely, if they get COVID-19, to end up with a more severe illness that will end up requiring more severe therapy than would otherwise have been the case.
Well, Doctor, I mean, in your study, you reported that there are regional differences across Africa from one country to the other in terms of infection rate and severity of cases. And most of the affected countries are in North Africa. And then in Sub-Saharan Africa, South Africa has a higher rate. You've talked about tourism, countries that have importation from heavily infected parts of the world. But beyond tourism, are there other factors? Like, for example, the weather. Is it that exposure to sunlight is part of what has been protecting us in Ghana, in Nigeria? Or could the higher numbers in, say, Egypt and South Africa be as a result of the fact that these are countries that do a lot of testing? And do you really think the Nigerian response has been good enough?
Thank you for that question. True enough, what we find is that countries, particularly in the Maghreb, so countries like Morocco, like Egypt, like Algeria, Tunisia, Libya, if you look at the top 10 countries in Africa, 5 of them are from the northern part of the continent. There's 1 from the southern part, which is South Africa, 2 in the western part of the country, which is Ghana and Nigeria, and of course 2 in the east, which are Ethiopia and Kenya. What clearly has shown is that if you look at the current figures, South Africa alone is responsible for about almost 40% of the total cases in Africa. And we do know that the spike occurred during their winter season. The southern hemisphere generally tends to have their winter during the months of May, June, July, which was when South Africa saw the marked spike that is responsible for the current figures that they have. But as you rightly have identified, the number of tests is also a reflection of the total numbers that you have. So South Africa has done almost 5 million tests, followed by Morocco that has done close to about 4 million. And you'll find that the numbers seem to reflect also your capacity to actually do those tests. So that's also an important factor. If you don't test, you won't detect. And the number of tests you do is a reflection of the total number of cases that will be demonstrated. But also, like you rightly have identified, sunlight, heat, humidity also seem to be other factors that the report also has thrown up. And you'll find that countries around the equator generally tend to have much lower numbers and lower levels of severity compared to other countries. One, because of the temperature. Of course, in southern part of the country, of the continent, temperatures during the winter season were high. And you'll find that everywhere, including Europe and America, as they're moving towards their winter season, their numbers are also spiking and they're getting their second waves. But also the fact that, close to the equator, you find that you're more exposed to ultraviolet B light. And the ultraviolet B light is known to be the one that helps to induce your production of vitamin D. And it's been clearly demonstrated that vitamin D helps to protect you from the severe forms of the illness. And so clearly countries that seem to be closer to the equator generally tend to have better outcomes than those at the extremes. And that's why you'll find also that those extremes in South Africa and the Maghreb, those comorbidities that I mentioned earlier, things like hypertension, things like diabetes and obesity. Obesity, the prevalence of obesity is highest in the extremes of the continent. Maybe that has something to do with, the affluence of such societies. They're the ones also more likely to have more flights. There are more flights of people going into the Mediterranean, region to resorts in Egypt, Tunisia, Algeria, and several people also going to the southern part of the country. So the more flights that come in, the more the number of cases. But the odd thing that also has been reflected by that report is that if you look at the case fatality rate, which is the number of people that succumb to the illness when they acquire the illness, you find that the worst statistics are in the Maghreb. I know the Maghreb generally are populated by people of generally Arab origin, while of course sub-Saharan people are people of African origin. So is there a factor, or is it just a factor that is related to the prevalence of those comorbid factors that we might have mentioned earlier?
Well, that definitely
There's still a lot that we don't know.
Yeah.
But it's just, I mean, the report has looked at all the statistics.
All
and
that
our
should
belief
be
is that the
interrogated.
experts will be able to, using those statistics,
Well,
help to
as we
plan.
run out of time, I'd like you to quickly address the current vaccine race in about a minute. You would have noticed, I'm sure, the rapturous coverage by the media and politicians like President Obama is still called, volunteering to roll up their sleeves. Deputy Medical Officer in the United Kingdom, Professor Van Tam, saying he would urge his mom to take the jabs. What are your thoughts on that as weighed against the potential for side effects and the risks and the lack of balanced scientific information being put out?
I didn't hear the question clearly, but I presume that you're asking about vaccination.
Yes, doctor.
Okay. Now, it's refreshing and reassuring that, quite a few vaccinations have been developed, which hopefully would help to prevent and curtail the pandemic as it is. But as you have rightly identified, many of these tests, the trials, were carried out not using people of our own origin. They were mainly carried out in Europe and the Americas. And naturally, the trialists would have skewed their trial participants towards more the Caucasians and the Africans. So clearly, what I would recommend is that to some extent, we have to do trials within our own continent because we're never sure those side effects that have been identified might be a little more severe when it comes to us, or be non-existent. You won't know until you do the test. I think it's inevitable that we would have to administer the vaccine. But the concern is that normally the process for producing a vaccine takes about 6, 7, 8 years. Somewhat, we've been able to produce these vaccines within about 10 months of the onset of this pandemic. So, to be honest, there hasn't been enough, trials carried out to be certain that there won't be any long-term effects. But most of the countries are now, allowing emergency use of these vaccines. And the projection is that whatever it is, the severity of whatever side effects that there might be won't be enough to deter long-term advantages of protecting all citizens. For you to have the protection and develop what you call the herd immunity, you really should be thinking of vaccinating about at least 60 to 70% of the population of any country. And I'm impressed by the UK that have actually given the approvals, and it's speculated that within the next week they could actually begin the vaccinations in the UK. The cost of the vaccines might actually be an issue. The Moderna and the Pfizer vaccines are in the region of about $30 to $40 per dose. And what I suspect is that we in Africa are more likely to use the AstraZeneca Oxford vaccine, which is a lot cheaper. I presume it's about $3 to $5 per dose. And that, I'm told, also, some trials have been done in India. And a lot of the production is being done in India as well. So that is the one that I suspect might eventually get to us in Africa, coupled with the fact that the modalities for preserving and transporting the vaccine are a little more favorable for us in Africa with our, limited resources and capacities than the ones that require you transporting and storing them in minus 70 degrees. With the AstraZeneca vaccine, it's possible for you to store it in fridge temperature between 0 and 4 degrees, and for the vaccine to still remain potent. So my advice is that when the vaccine comes, the country would almost certainly have to develop a protocol, and who are those who would be the first in line to receive the vaccine. And I suspect that medical personnel at the forefront of, the care and of individuals with this disease should probably be one of the first few people to get the vaccine. Then the vulnerable people in our environment, the elderly, the diabetics, the individuals who are obese. And then progressively then, in age brackets, we will come down from the 80, 70, and eventually come down to the much younger individuals who seemingly are less vulnerable when it comes to the severe effects of COVID-19.
Well, certainly there's still a lot more to talk about. What should African governments be doing, and what is the future of humanity? But we would like to thank you very much at this point, Dr. Bamgboye, for joining us on the morning show. Thank you very much indeed.